research. So we would discuss the various types of studies that can be conducted and which one of them are appropriate to be conducted in a busy setting. When we talk of medicine, when we talk of medical education, when we talk of medicine, so patient care is one of the components of medical education or the practice of medicine. The another two important pillars of medical practice are teaching and research. So we can see from the definition of a study that we are trying to look at a question, which is a focused research question, which will be discussed in the subsequent lecture, that how do you make a focused research question. And here we are trying to collect some data from a subset of a population, that is a defined or a defined sample of a population. So it starts with the study question. So whenever you are planning to do a study, it starts with some deficit in knowledge, some gap in the knowledge which you're trying to identify, gap you are trying to bridge, some study question, and then you would see what type of study am I going to conduct. So once you have a research question, then you are going to collect some data, and every study has different methodology of collecting data, and each study will be different in in giving inputs to a different type of questions. So each different type of study question, we will also discuss this subsequently in this lecture, that each study question will be appropriately answered by a specific type of a research study, followed by collecting and analyzing the data and interpreting the result. So knowing the type of a research study is something of paramount importance, something very important to start the research. Often you would have seen, you would have encountered even your residents, your colleagues, that whenever they are, trying to submit their dissertation, even their thesis dissertation, or even as a reviewer of a paper, you would see that the type of study is either written incorrectly or is a type of study dealing with. So this is an old in which defines the study broad types. So we can divide the studies into two broad types: the descriptive studies and the analytical studies. So descriptive studies, as the name suggests, is a description of something. So we are just describing the data which is available to us. We do not have a comparison group. We are not comparing the data with between the two groups or more than two groups. Whereas the analytical studies are trying to analyze something. So when they're trying to analyze something, they're trying to compare. So they're trying to compare the two groups or more than two groups, or they're trying to compare two things against certain set standards. Whereas descriptive study, they will have only one study group, and they are trying to, just describe the findings in that study group. The types of descriptive studies, there are four basic types of descriptive studies: case reports, cases, cross-sectional studies, and typological studies. We'll describe them one by one. When we talk of analytical studies, we'll come to them later on. Analytical studies, here, remember that we are trying to compare two groups together. So there can be cohort studies in which we are trying to compare two cohorts, case control studies in which we are trying to compare the cases against the controls, or interventional studies or the trials. We'll discuss the differences between all different types of studies subsequently. When we say case report, it's a detailed presentation of a single case. Okay, so sometimes you would see a very clear case in your practice. You have done a very novel technique which you think is not described before, a rare presentation of a disease which you think has not been described before, or has been very seldom described before, or a new surgical procedure for an indication which you think is a novelty in itself. So when you're trying to describe such a situation, it will be a case report. all of us are familiar with case reports, and now um, we know that it's a description of one or two peculiar cases. So these case reports, although they come at the very, very basic level of the evidence, when we discuss the strength of the studies, the how good the study is, what the strength of the study, these forms a very basic or level of the evidence that could be generated. So a lot of our practice cannot rely on case reports. We cannot change a practice based on a case reports, because these are very rare descriptions of some things, but they are again helpful because they help us to identify the rarer manifestation of certain diseases, rare surgical procedures which can be assembled, can be assimilated in a practice later on. Case series is simply it's basically a series of the rare cases, more than about 5 or 10 cases of similar type presented together would form case series. Now, these cases are individually they are studied in detail. They present something which is not of a very common nature. So, for example, a rare type of certain fractures. For example, you're trying to describe a series of your Pofas fracture in the knee. You are trying to describe a series of your coronal shear fractures of the elbow of the knee, or a rare case series of a new implant which have been introduced. For example, a new processes for the humeral head replacement. So you're describing, so you are not comparing it with anyone. You do not have a comparative group here. So you're just describing about 15 cases of a new surgical technique, or a new implant, or a new presentation of a disease, or a rare presentation of a disease in itself. So it will be a description of a few cases of similar kind described together, but again without a comparison group. So we all are again very much aware of this type of studies, and in orthopedics again we would see a large number of different type of case series. So we do publish case series many times we have described, for example, 20-25 cases of a new approach to a joint, or for example we are describing a 25 cases of for example direct entry approach to the hip joint. But if we are not comparing it with any other approach, we are just describing outcomes of 25 cases of operated by a single newly described approach. So that's a case series. Ecological studies, and I'll discuss the ecological studies and the cross-sectional studies together. So most of us are aware of what is the cross-section study. So we'll discuss the ecological study subsequently. When we say cross-section studies, we are taking a cross-section of the population at a given time. For example, this is again a commonly done studies, particularly in orthopedics, particularly in a busy clinical practice. This is again a commonly performed type of study in which you are taking a cross-section of a population at a given time. So you are studying characteristics or a distribution or a dispersion of the disease in a population at a given time frame. So for example, you are looking at the population at a given time. For example, you are trying to look at the entire page, the population that's presenting to you within this month. For example, you're looking at the patients of osteoarthritis presenting to you in this given month, and you are trying to look at how many of them are diabetics. So you're looking at prevalence of diabetes in the patients presenting to you with osteoarthritis. So you're looking at presentation of a disease in the population at a given time frame. So they are also called prevalence studies because with this you can calculate so with this you can calculate the prevalence of a particular disease or a disorder in the population at a given time. When we say ecological studies, in ecological studies they differ from cross-sectional studies because we do not calculate the individual level information. For example, we are looking at the reported rates of PPRP, post-polio residual paralysis, in different states in India in the month of March. So we are looking at the data from the state. Or for example, we are looking at the proportion of patients vaccinated with COVID-19 vaccination in different states in India. So we are looking at a state level data, or we are looking at a district level data. That is a data from a group of individuals rather than an individual itself. Then it is called an ecological study. So generally in orthopedics or in clinical practice, we are not doing an ecological study. These are generally performed by an epidemiologist, and these are generally not within the purview of a clinician. Clinician would most likely be performing a cross-sectional study. And cross-sectional study is a simple study to perform. Many times you want to look at, for example, you are trying studying uh, handling the patients coming to you with insertionitis or pregnancy disease and want to see their occupational history. Then it's again a cross-section study. You're trying to see that what different occupations may be associated with this particular type of a disease. Next, coming to the comparative studies or the analytical studies. So here we are trying to analyze certain factors. We are trying to compare the two groups. The first of them we'll study here is a cohort study. The word cohort is derived from the army, which means a group of people or a group of a population. The design of a cohort study is like we are going now from exposure to the disease. Now, once we are saying it's the cohort and the case control studies, and once we are differentiating it from the analytical studies. So if I go back to one of my older slides in which we were discussing the type of the studies, and we say that analytical studies can be observational studies or interventional studies. So observational studies are the studies which are based on a natural exposure, in which we are not deciding the exposure. We are already taking the people who have been exposed to certain natural phenomena. In interventional studies is when we are trying to control, when the examiner is trying to control the intervention. For example, I'm giving some drug to a population and I'm not giving that drug to another group of population, and I'm comparing both of them together. So that becomes an interventional studies because I'm controlling the intervention. Okay, similarly, if I'm doing a surgery, I'm operating by procedure number one in one group, or the other group is either treated non-operatively or by any other surgical technique. So that becomes an interventional study because I can control the intervention. But once I cannot control the intervention, for example, I'm taking a cohort of diabetic patients. So the patients who have already been diabetic, it's not under my control that I can control whether the patient has diabetes or not. They already have diabetes, and I'm taking a cohort of a diabetic patient and looking at the incidence of osteoarthritis in them later on. Right. So that's how we are differentiating between observational studies and interventional studies. And observational study, the first example is the cohort study that we are going to discuss now. So cohort study, you have two groups of people who have been exposed to a particular exposure or a particular thing of interest, and another group of people who have not been exposed to that. They are followed over a certain period of time, and it is seen over time whether they develop this disease or they do not develop this disease. So we are able to calculate among the exposed how many have developed the disease, and among the non-exposed how many have developed the disease. Then we'll compare. For this is one of the examples of a very famous cohort, which was a Framingham study in which patients with hypertension and patients without hypertension were followed up for a long period of time and seen for the incidence of a coronary vascular disease. So study population selected, baseline information is collected, they are followed up for a long time and analyzed for the disease. So among the exposed, disease and non-disease, and among the non-exposed, disease and non-disease. We know the total numbers from the beginning. What we calculate from this is the relative risk. So that is basically the incidence of disease in the exposed divided by the disease incidence of the disease in unexposed. And relative risk of 1 means the risk is same in between the two groups. Relative risk of more than 1 means that incidence is higher in the exposed group. That is, the exposure is strongly associated with the disease. Relative risk of less than 1 means that the exposure is protective against the disease. That is, the patients are exposed to this intervention, to this thing, then they are less likely to have the disease. Cohort study are difficult to perform, particularly in a busy clinical settings, because they need a lot of follow-up. So the patients have to be identified, recruited in the study, and they have a long follow-up for which they have to be followed. Multiple outcomes have to be studied. So once you have the patients who have been exposed, for example, you are studying a group of patients who have diabetes, you are looking at an outcome, but there may be many other outcomes. Diabetic patients may have many other things which may need to be studied. It is good for investigating rare exposures, but it is not good for rare disease. For example, if the disease is very rare, then you will need a very large cohort of the people who needs to be followed for a long time. So your sample size is very high. So you have to, the studies become very time consuming and also expensive, because you have to keep and following up a large data of the population. The converse is the case control study. The case control study goes from the present to the past. Okay, so it goes from the outcomes to the exposure. So you are already selecting the patients who have the disease, and you are going in the past and trying to see whether they were exposed to that disease or not. The strength of a cohort study is better than strength of a case control study, because those studies were more or less prospective. So you have gone from the exposure to the outcome. But since here you are going from the outcome to the exposure, they are sort of retrospective studies. And the strength of cohort studies will be better, but they are more difficult to perform. A case control study are more likely to be performed in a busy clinical settings. For example, many of our orthopedic studies would be done by the clinicians. They are easier to perform. There will be case control studies in which you will have cases. For example, you will have cases of osteoarthritis of the hip joint and patients with a normal hip joint. And then you go back into the history, you go back into the examination, and maybe you are trying to look at the old x-rays, or trying to look at whether they had features of hip dysplasia in the past or not. So you have taken two cases, two groups of people. One is the cases who have hip osteoarthritis, other is the controls who do not have hip osteoarthritis. And then you're going into the past and you're trying to look at whether these patients had exposure to hip dysplasia or not. They are good for examining rare outcomes and rare diseases, because you're already picking up the cases with the diseases. So the sample size will be less. They are easier to perform. They have fewer subjects. They are mostly quicker and inexpensive to perform. What we calculate from them is the odds ratio, which is the probability that the case was exposed divided by the probability that the case was not exposed. So odds ratio will be odds that the case was exposed divided by the odds that the controls were exposed. So A, D divided by B, C, this is the formula that gives you the odds ratio. Interpretation of odds ratio is similar to the relative risk. Odds ratio is 1. It means that odds of exposure among the cases and the controls are the same. Odds ratio of more than 1 means exposure is more among the cases. Odds ratio less than 1 means exposure was less amongst the cases. Now, the last type of studies were the interventional studies. Interventional studies, many of our studies on the surgical techniques, on different drug trials. For example, you're trying to compare two different NSAIDs for post-operative pain relief. You are trying to compare the nerve blocks in the post-operative periods with the opioids. We're trying to compare two different surgical techniques. They are all interventional studies, because here we are defining the intervention. We are defining what we are giving to the patients. We are dividing the patients into two groups by ourselves. That means the division into the two groups is decided by the investigator. And we are looking at the outcome, which may be a change in the disease pattern, change in the outcome scores. Now they can be randomized or non-randomized. So interventional studies are also called trials, and they are divided two groups. That is the randomized controlled trials and the non-randomized controlled trials. Now, if we look at the hierarchy of the evidence, the randomized controlled trials form the best type of the research designs, in which a study population is taken, and by a process of randomization, which ensures that each member of the study population has an equal chance of going into either of the two groups of cases and interventions. So they are divided into two groups, the controls and the intervention group. They are given the intervention and the outcome is compared between the two groups. It gives an evidence of causality. That is, the outcome has definitely caused that incidence. Randomization ensures that two groups are similar. So we are comparing like with like. So we are not comparing, do not have a bias. That is, we do not have one group which was already more susceptible to have that particular outcome. But again, it is slightly more difficult to perform because you need randomization, you need a lot of participants, the sample size will be higher. Sometimes randomization may not be possible, sometimes blinding may not be possible because if you're comparing a surgical technique with a non-surgical technique, then of course the surgeon knows in which group the patient is, the patient knows in which group he lies, and the person who is assessing the outcome may also know while looking at the scar at the surgical site that what has been done to the patient. Now, the last type of studies are the systematic reviews, meta-analysis. So systematic reviews and meta-analysis are the the reviews which have been done in a systematic way. So what is systematic about systematic review? The method of literature search and critical appraisal. So systematic review would mean that you have a focus research question. You are looking at one particular type of a research question only. For example, if you're looking at carpal tunnel, so you are probably looking at, for example, your question is whether endoscopic release of carpal tunnel is more effective than an open release. So you're looking at a systematic review on these. So you look at all the studies that directly deal with this focused research question. You accumulate the data of all the possibly available studies on this topic, and then you summarize the data, you form the inferences from the data. On the other hand, a narrative review is like a book chapter. It's basically, if it's on carpal tunnel, it will give you about the pathology of carpal tunnel syndrome and the diagnosis of carpal tunnel syndrome, risk factors for carpal tunnel syndrome, various surgical description of various surgical techniques for carpal tunnel syndrome. So that would be a narrative review. Levels of evidence, something very important. Expert opinions, case reports are the lowest level of evidence, level 5. Uncontrolled studies, that is the cohort studies, case series, again they're level 4. Case control studies or the retrospective cohort studies. So uncontrolled cohort would just basically mean a case series. Here when we are talking about retrospective cohort study, I said it's like a case control study because it is retrospective. So all retrospective studies going to level 3. Prospective studies, prospective comparative studies, that is the prospective cohort studies, and non-randomized trials, they will be level 2 studies. So all prospective studies, level 2 studies. Level 1 studies will be randomized control trials or systematic reviews or meta-analysis of randomized control trials. Research is a collaborative effect. You need a research team, you need a epidemiologist or a biostatistician with you. It's preferable to have so that they can help you in guiding your samples and also sometimes the biostats, because not everyone would be very versed with the biostats. One of your colleagues may be able to do it for you if you are not able to do it yourself. Different types of questions are best answered by different types of study. This is something very important. We say that the level of evidence is level 1. The level 1 evidence is, we said that meta-analysis and randomized controlled trials. But it is not possible to have randomized controlled trial on every question, every research question. Every research question cannot have a meta-analysis. So we have to look at what is the best alternative type of study for a particular type of a research question. So when we say it's a research question related to a particular intervention, for example, we are comparing 2 drugs, or we are comparing 2 types of surgical techniques of therapies, it's a randomized controlled trial. When you're looking at diagnosis or screening, cohort studies. When we're looking at the prognosis, longitudinal cohorts of a particular disease, they form the best type of the evidence. Etiological or risk factors for this, again a randomized controlled trial. If randomized controlled trial is not available, a cohort study. If a cohort is not available, a case control study. So I would like to finish here and thank you again, all of you.
Thank you very much, Tarun. There are some questions in the chat
Yes,
box. I'll come back to those questions once again. But before that, can you stop sharing your screen so that we can start?
sure, sir.
Thank you very much, Tarun. That was a excellent. Excellent presentation. So because of lots of rush, I had to skip certain things. So let me introduce my faculties today. Let me welcome on behalf of Nepal Orthopedic Association, Dr. Sujit Kumar Tripathi. He's additional professor at Department of Orthopedics at AIIMS, Bhubaneswar. He has lots of involvement in various papers, more than 160 papers. He has some editorial experiences as well, and he has won several international awards. Thank you very much, Dr. Sujit, for accepting our invitation to deliver a talk on research questions.
Thank you, Dr. Joshi. Thanks.
Let me introduce all the faculties so that we don't have in between any hiccups. We just heard Dr. Tarun Goyal presenting, a paper on how to select which type of study will be, appropriate for a busy clinician. We will have lots of questions in the chat box. We'll discuss this on our panel discussion as well. Dr. Tarun Goyal is an associate professor from Bhatinda, AIIMS. He is a therapeutic-trained joint replacement and arthroscopy surgeon. He's faculty in field of medical education and research in orthopedics at various forums, has about 95 international publication, book chapters, and so many. And he has editorial experience with IGO and JCOT. So it will be very interesting to understand their point of view on various aspects of research. Let me introduce my colleague, Dr. Nagmani Singh, consultant orthopedic and arthroscopy surgeon at AKB Center for Arthroscopy, Sports Injury and Regenerative Medicine. He is editor of BNB Medical Journal and reviewer of several national and international journals. He is chief of Institutional Review Committee at BNB Hospital. He has more than 50 publications in various national and international journals, and a winner of several awards. And he'll be delivering us a practical session of how to search basic literature regarding your topic. I'm privileged to introduce a very good friend of mine, Dr. Lakshman Rizal. He's one of the very famous orthopedic surgeons of our country. He's visiting faculty at Karnali Academy of Health Sciences. He's fellowship trained in upper extremities and hand. He has various fellowship from Singapore and Japan. He has lots of international publications. He has written chapters in various books. He is presently writing an e-book in orthopedics for undergraduates, and he's editorial member of International Journal of Orthopedics. Welcome, Lakshman, and thank you very much for accepting our invitation at the last moment. And last but not the least, I'm sorry to say that Ravindralal sir is busy because of his family work today. His serious issues at his home. But Dr. Ravindralal Pradhan is president of Nepal Orthopedic Association, and he's the key person behind organization of these kind of webinars. He is professor of orthopedics and head of department at Kathmandu Medical College. His country leader, AO Spine, Indian Subcontinent Council member. He's a member of research committee in Asia Pacific Spine Society. He has lots of editorial experiences. He was the first chief editor of Nepal Orthopedic Association journal. And then he has several papers on his name. So with this, on behalf of Nepal Orthopedic Association, I'd like to thank everyone, all the faculty, each of you, especially Tarun and Sachin from India, and Tarun and Sujit from India, for sparing certain time to share their experiences with us. And a special thank to Lakshman Rizal also, for the last moment addition to our team because we wanted his experience as a private practitioner on research, how to conduct research. So thank you very much. Sujit, now you can unmute yourself and start sharing your screen and go ahead with your presentation. Yes, Sujit, your screen is visible. You can go ahead.
So you can see the PPT now?
Yes.
Okay. Thank you, Dr. Joshi. And that means Tarun introduced the topic nicely. So I will be speaking on how to make a research question. But before that, I would like to share my thought about research. So when I was actually a resident, at that time, I was not involved in any types of research. And that means I was just thinking that it is a job of all those persons who are not busy in their clinical practice or who are not doing any orthopedic practice, whose practice is not going in properly, probably they will be involved in the research. But somehow my concept changed after some time because when I passed my master in surgery, MS degree from PGI Chandigarh, at that time I applied for senior residency at multiple of centers. But unfortunately, I was not selected in any of them. I visited almost 20 to 25 centers. Everyone was asking me one question, that how many publications do you have? What type of research experience do you have? And that was the scenario at that time. Then I realized that probably research is mandatory, not only for that means to get one field. Subsequently, when I published few articles, and I feel that people now start recognizing me because of my research, and probably I could contribute something to the literature. And that's how my concept towards research changed, and I become a permanent researcher along with an orthopedic surgeon. So that was my experience towards research. And I'm very happy to see that almost 145 participants are participating in this research, that is your research presentation. That's very good number. So I'm really thankful to the Nepal Orthopedic Association for giving me this opportunity. So we'll start how to make a research question. Before going for any research, we need a question. That means what is there in our mind, what we are going to answer. So that should be perfect, because unless you have a perfect research questions, probably you will not be able to convey the message, or you will not be able to get the result properly. So nothing to the conflict of disclosure. I have nothing to disclose about these presentations. So let me say, what is the research? What is the definition of research? If you say this is the process of a systematic process of collecting the data, analyzing the data in order to increase our understanding of the phenomenon about which we are concerned or interested. So if you analyze properly, there are three processes here. One, there is a systematic process. Second, we are collecting and analyzing the information of the data. And the third part is actually we are concerned or interested. That means we are concerned about our project or about the study. So that is what the research means. So when we are interested in one part and we are collecting or analyzing the data related to that study, then it is probably called as research. So just see, there are purposes of research. Either it can be an exploration, that means when we are trying to investigate a new problem. It is just a rough estimate. So suppose we are trying to look for the drugs causing avascular necrosis of the femoral head or osteonecrosis of the femoral head. So that is called as exploration study. Descriptions, probably how this drug is causing, that means how describe that what percentage of populations are actually involved. That means which particular population is free from the drug effect. So that is called as descriptions type research. And last one is the explanation. That means how we can correlate how the drug is actually causing, what is the pathomechanism behind that. So that is called as explanatory research. So there are three possible types of research: explorations, descriptions, and explanation. And Tarun has probably told all these things. So explorations means when we are, that is exploring, or it is a rough understanding of a phenomenon. It can be in the method of a literature review. You can do interviews, case studies, or key informants. Descriptions, it is a precise measurement and reporting of the characteristics of the population or phenomenon. There is what percentage of the cases, what is the case, what is the nature of the relationship. So these are usually established by census, surveys, and qualitative studies. And what is explanation? What is their relations? Justifiable relations. Suppose steroid is causing osteonecrosis. So we have to analyze what factor, how the steroid is causing avascular necrosis. Does it have hyperlipidemic effect? That's why it is causing the effect. Or it has a direct cytotoxic effect. So when we establish a causal relationship or relationship, it is called as explanatory type of research. Now, let us discuss this process of research. It's a process because it is we have already mentioned that it is a systematic process. And the first and foremost thing is the defined research questions. There should be a question that we are going to answer by doing some research. After putting a question in your mind, what the next step is the conduct literature review. You have to review all the available literature on that particular topic. Then probably what you need to do is refine the questions. So remember, this question is not static. Initially, you thought that probably why anterior cruciate ligament rupture or deficient patients are developing osteoarthritis knee. So you try to do something and know what I will do. I will aspirate all the synovial fluid of the knee joint. I will send them for cytokine evaluations. And on the other side, for a control group, I will measure the cytokines. And probably I can better correlate the cytokine level to the onset of osteoarthritis. So that is what in your mind. Then when you did the conducted the literature review, you found that probably not all cytokines are responsible. Probably you need to do few selective interleukin 1, interleukin 6, MMP, metal matrix proteinase, and TNF, TGF beta. Probably those 4 cytokines are responsible. So now you refine your questions. So when you do the conduct the literature review, you found a hole in the literature, that the literature is not clear. We don't need to, that means evaluate all the parameters. Probably we need certain few parameters only, or there are certain unanswered questions. So we refine our questions. Now what we propose, we'll see only the level of interleukin 1, interleukin 6, and TNF alpha levels in ACL deficient knee. So after refining the question, then you operate the variables, design the study, and before recruiting the patient or before taking the consent of the patient or collecting the data, you have to obtain the institutional review board approval or institutional ethics committee approval. That is the foremost thing. And then you collect and analyze the data and write and report the results. So these are the steps of research. Now, first question, I've already mentioned that the research starts firstly with a questions. So it is appropriate to have a proper questions. So asking the right questions, how it is important, because what you ask, how you ask, and where you look. That means what you ask means what is there in your mind. How you ask means how you are formulating your questions, and where you look means how you are doing the methodology part, how you are doing the study, and that intersection is what you find. That is your result. So if you analyze it properly, if your research question and idea is perfect, probably you can have a very good interpretation, a very good result at the end. Now, benefits of proper questions. It improves the clarity of the problem. So you just cannot, without a question, suppose you think something in your mind that I will go for a research, I will just see that how the steroid causes avian. Now, if that is the only problem, you just decided one day that, yes, I will go for steroid causing avian. Next day, when you started collecting all the data, after the end of your study, you found that probably you have collected, that means all the types of steroid of 1 day. Some patient is taking for 1 day, some patient took it for 1 month, and some patient took it for lifelong because of their certain immunological problem. And ultimately found that probably you have nothing in your, that means when you found the ultimate part of your study, you found that almost 90% of patients have taken steroid for 1 day, and the outcome of the study is almost nil because none of them developed avian. So what you found is that there is no incidence or there is no onset of avascular necrosis of the femoral head because of steroid. So improves the clarity. What you are looking to go first in this study, that I will probably take 1 month of steroid intake of certain degrees, about 60 degrees like that. Then so that should be the clarity of the problem should be clearly defined. It facilitates subsequent steps of the research process, because if you have something in your mind, if the research question is properly designed, your methodology also progress accordingly. Then the third part is it helps to select appropriate literature for review. So if you are very certain that if you have a focused problem, then you can search the literature accordingly. Those particular literature you can search and gain more detail into this type of study. Then you anticipate certain issues, the resource need, that means whether money is needed or not, whether I can recruit the patient of that particular type or not, that you have to evaluate while formulating the proper questions. So it overall improves the efficiency and minimizes the wasted efforts. So unnecessarily the wrong thing that you are collecting for a methodology or unnecessary things which are probably not needed on your research study can be excluded. So these are all the benefits of having a proper questions. Now, the next part is before going for a research question in your mind, what is there in the idea? There should be an idea. Unless there is an idea, probably you cannot have a research question. So formulating an answerable research question from an idea is the first thing that happens. And it is basically of three phases. First, there should be a problem. Unless there is a problem, there will be no interest in research. So there is a problem because I'm giving one example. One person is doing double bundle reconstructions of ACL. His patients are doing pretty well in the post-op period, and the other person is doing single bundle reconstructions. And that patients, they are doing well, but not that much as that of double bundle. So you are not that means acquainted with the technique of double bundle. So you thought that probably I will see what's the difference between these two techniques are. So that is the problem. Basically, you realize that probably double bundles are doing better. So I have to evaluate or compare these with double bundle technique. So that is the problem in your mind. Then idea, where you will get the idea, probably by reading the literature. You will see the literature, what the literature is saying, whether double bundle is better or single bundle is better. What the media is saying, what is the conference, brainstorming, and discussion section. So don't ignore the media part, because as a researcher, many times we think that probably it is better to only go for the medical literature, what is written there in your journal articles, but that is not the things always. If you read the media also, sometimes many new things come. Like the Trump took some cocktail regimen in for the COVID, which was actually not there in the literature in the initial part, but subsequently many literature came, particularly with that cocktail, because that gained attention among the researcher to research further, because how can one drug can be given to one president? So that's how the media attracted the researcher to investigate on one particular product. So that's how we gain the idea. So from problem, we gain some idea about that topic, and that subsequently formulate a question. So these are the three processes, those are interlinked. So these are all the methods of getting the idea. You can rational thinking, brainstorming, relevance trees, discussions, exploring past projects, keeping an ideas notebook. So many people, what they do, they write their notebook. And few people, what they do, they keep on writing their ideas, that comes to their mind at different times. So probably that also helps at certain period, because ultimately you are going to see your ideas and formulate the questions. Now, the research idea provides the very basic foundation of your research work. Without research idea, there cannot be research. And our intention is just to enhance our knowledge about the situations. So we have to gain further explorations and relationship, or to augment what is there in the literature, and further what we can add to the literatures. So there is a research problem. I have already mentioned, from problem, it leads to idea. So how to understand the research problem is also important, because the research problem should be understandable, and it should explain the problem. What I am going to study, why and how, all this thing has to be done. So that is the research problem, and it sets the frame of reference for the study. And defining a research problem is clarifying oneself what is the problem and what the researchers is intended to do, or what are the expected outputs. So this is how the research problem is first configured in the brain of one person. Setting up the research problem, that is looking for the rationale, arriving to this problem. That is, what is the literature gap, what is their interest, whether you have interest or not. All these things has to be seen further before starting the research questions. Then collecting preliminary informations about the trial, then reviewing the literatures, and discussing with stakeholders, other researchers, whether the trial is possible or not. And finally, it is the statement of the problem. So ultimately, what I'm saying is that from the problem and gaining the idea, after that you are formulating research questions. And initially, I would say you frame multiple types of questions. You make almost 10 questions. First, you write that, does omnacotyl, the methylprednisolone, cause avian? Second, you write, does deflazacort cause avian of the femoral head? Like you write down many steps. Then you write that whether 20 milligram of methylprednisolone cause avian, whether 60 milligram cause avian, whatever is coming to your mind, you just write down. Ultimately, you narrow down and come to one research question. So that is the principle. Frame multiple questions and narrow down gradually to one research questions. And the final research question should be most interesting, feasible, that should be possible in your setup, fundable, there should not be any monetary issues, and best overall. So that is how you are going to formulate your research questions. So it is a cycle of event. You cannot say that this is a fixed idea and I have decided, means I will go for only looking for this particular aspect. It is a continuously evolving idea. So the research questions is modified by the ideas, and it again modifies after reading some topics. You will find that probably I will add this much or I will remove that portion. So by which your research question gets filtrated every time. And when you do you start the study, suppose you have done a preliminary study before recruiting the patients. From the methodology also, you can reframe the questions from the initial few cases. Those should not be your research part. Now, the research process, I have already mentioned that your research question because if there is any problem, then probably you can go for refining the steps. Now, the research guide, then I want to share this picture, what is called as domino effects. Many people say that it is like a guide pole. Guide pole means if your question is proper, now when the ships are coming to the sea, you will see that they are guided totally by your light pole. When they see the light pole, probably they drive towards that directions. And the research question has similar effect. Your research questions leads the researchers to frame a proper methodology, and that is called as domino effect. That means the research question actually guides about the sample size, it guides about the types of participants, it guides about the types of study possible and what are the results that we want to see from the study. Now, there can be a single research questions, there can be multiple questions. So big studies, international collaborative studies, you have seen that probably they take multiple questions into their research study. But for us, probably when you are a single researcher, you are trying to solve one problem, it is better to have a single research questions. And that questions I have already discussed that it is dynamic, it changes with time, frame multiple of questions initially and gradually narrow down to one single questions. Then it can be a quantitative research questions where the parameters are numerical, but it can be qualitative research questions. Suppose you wanted to see the infection in case of diabetes mellitus, whether infection is present or not, that is called as qualitative research questions. But when you wanted to see that which particular patients are developing there is a diabetes and what percentage of patients, that is called as quantitative, because 50% of the patients of diabetes having hemoglobin A1C more than 8 are developing infections. So now you are coming to evaluate the incidence or prevalence of particular problem in particular set of the population. So that is called as quantitative research. And in many studies, we do mixed method. We both evaluate it qualitatively and quantitatively. Now, we have already discussed the three types of research that are like exploration, description, comparison. Similarly, the questions are also three types. Descriptive research questions, which measure the response of a study's populations. Then comparative, when you compare between two groups. And the relationship, when it is the association or correlations, when you try to find an association between one drug and one outcome or one particular disease or one particular intervention towards the outcome, then it is called as relationship research question. Now, steps to develop a good research. Basically, this is overall, this is what I should say. Start with a broad topic, do preliminary research to learn about your topical issues, narrow down your topic and determine potential research questions. So multiple of questions are there. evaluate the soundness of your research questions. So these are the 4 steps from which you can formulate a good research questions. And if you read the article by Hule et al. 2007, probably this is what you need to see the finer concept or finer criteria, whether the research is feasible at your setup or not, it is interesting or not, novel, ethical, and relevant. Remember these 5 part or 5 criteria. If your research question fulfill these 5 criteria, probably your question is good. So coming to the first part, feasible. Are you fascinated by the topic? Just see, I'm an arthroscopy and arthroplasty surgeon. If you someone will see, someone told you that there are many low back patients coming to our OPD. Some of them patients are responding to caudal epidural and some of them are not responding. So can we do a study? But listen, I'm primarily an arthroplasty and arthroscopy surgeon. I'm trying to develop my field in that particular arthroscopy and arthroplasty. What is the fun of doing a research topic which is based on spine? So I'm not fascinated by the topic. Second, do you have the necessary research skills? If someone will ask you, I cannot give the caudal epidural because I am not trained in that. Can you complete the project in the time available? Okay, you are giving thesis to one of your student whose thesis is going to be finished within 1.5 years, and you have given the outcome assessment of 2 years. How is it possible? We'll operate those patients within 6 or 1 year. Then that your student is going to follow that for another 6 months or 1 year. So it is not possible. So you just see whether the time available is sufficient or not. Will the research still be current when you finish? So now you have given a study on tranexamic acid, and there are multiple of literatures on tranexamic acid. So after 2 years, when you will publish, none of the journal is going to say, because it has clearly been established that tranexamic acid has already been proven. If you find few of the meta-analysis, they have clearly written that the beneficial effect of tranexamic acid in reducing blood loss has been clearly established, and now probably no more research related to the efficacy of this drug is needed. So that is why I think that you should be updated. Will the research still be current when you finish your study? And do you have sufficient financial and other resources? If you don't have a funding, please choose a topic that you can complete by yourself. And don't go for evaluation of all these cytokines, which will incur almost lakhs of rupees. And will you be able to gain access to the data? Suppose if your institutional policy is that you cannot access the case records and you have not collected the data initially, so probably you will end up with some problem, or probably suppose you have missed some data, you wanted to see the case records, and if your hospital is not allowing, then probably you cannot do anything. So see whether you can do the research in your setup or not. That is the foremost thing. Second is interesting. It should be interesting to the researcher. That means it should be of your outcome of interest. It should be the outcome of interest for your peers and the community. There is no point in doing a research which is of no interest. Suppose I will just evaluate, I will see how many patients are, that means walking barefooted in the orthopedic OPD. What is the point of doing that? Because no one is going to read that. So it should be of interest to your peers, to yourself, and to the community. Then novel. Novelty means there should be new insights into the field of the study. You should put something new in your there is research questions. So it should not be repetitive always. Or the question may confirm or extend the previous finding. If there are limited literature which have confirmed one certain finding, probably your research is going to further enhance the confirmations. So you can do that, or extend the previous findings. You can give some new messages along with the previous ones. That is what called as novelty. So that's how you have to propose the research topic. Ethical, it should be practical, feasible, scientifically sound, and it should not cause any harm to the patient. Suppose I am doing NT version of the hip evaluations in THR patients. And what I've chosen, I have chosen a modality like CT scan. But is it ethical to do CT scan for all patients after total hip replacement? You are giving so much of exposure to the patients. So your ethical committee, if it is there, they will strongly reject it, because CT scan is it is a dangerous thing for the patient, because it will give numerous radiation hazard to the patients. So that's why it is harmful to the patients, and it is not ethically allowable. There should not be any loss of privacy or confidentiality. There should be insurance cover if it is there, and review boards and the appropriate authority should approve it. So you should see whether ethically your study is perfect or not. And the last one is relevant. Will the examining institute standards be met? That means what study you are doing, it is as per your institution norm or not. It should be relevant to the scientific community. It should be of public interest and people involved in the area of the study. So there is no point in doing certain research where the researchers, or if something is already established and you are trying to repeatedly doing the same thing, then probably it will be of no help or to the society or to the researchers of same category. So the research topic also match your career goals. Suppose I wanted to develop myself as an arthroplasty surgeon in future, then I should choose a topic based on arthroplasty, not on spine or any other things. So this is how we formulate the research. We choose a wide topic, gradually narrow down, and formulate a specific research question that we are going to answer. So research that makes a difference, it should investigate an important question. It should be ethical. It should be connected to theory. I cannot say something irrelevant. So I will give, suppose I am planning to do one study where I'll be using adalimumab into the knee joint. So is it connected to theory? Is there any basis of giving a drug? It is not that is ethically correct and it is not theoretically correct. So it is not connected to theory. I will not do probably. Connects the study to prior research. So if it should be either augmentation to the prior research or supplementation to the prior research, and uses appropriate research design and analysis procedures and disseminates the results. So now coming to how to formulate, I have mentioned that I've given some examples and some criteria, what should be there in the research question. Now, what is the structure of your research question? It is called as PICO. Probably you all often know that. First of all, there is a problem or issue. You define the target population, what type of work category of population you are going to take. Then define the intervention, what you are going to do with these populations. Then if you are choosing a comparator group, choose your comparative populations. Then evaluate the outcome measures. So this is called as PICO format. Population of patient, intervention, comparator, and outcome measure. So these are the 4 components of your research questions. So it is a useful model. So let us see what are the structures are there. P stands for population, patients, or problem. I stands for intervention or indicator. C stands for comparator or control. And O stands for outcome. Sometimes it is not necessary to have an intervention and comparator. The other type of study is when we see the observational study. We take the P or patients or populations. Exposure, certain they are supposed exposed to smoking or certain drugs, then that is called as exposure, and we wanted to see the outcome O. So either it is a PICO format or PEO format. So I'm just giving one example of a research question. Is the outcome of augmented core decompression better than standard core decompression in osteonecrosis of hip? It is looking okay to me. That means if someone will read this particular question, he will think that probably I can do this research very easily. See what is the component, what are the components here? What is the population here? The osteonecrotic hip patients, that is called as P. What is the intervention here? Augmented core decompression, that is the I intervention. What is the control group here? Core decompression, that is C. And the last part is what is the outcome? I am going to see the functional and radiological outcome after augmented core decompressions. So these are the 4 parameters there. So one will be thinking that probably that this research question is fine. But if we go to the finer criteria, we will realize that probably this question also needs certain more stringent form or more specified form. So population, who are you interested in? How would you describe the patients or population of interest, and be specific? You just cannot say that a wide group of populations. I'm giving one example. Here I have mentioned it is the osteonecrotic hip.
Sujit, excuse me. Can you make it a little faster because we are overshooted by quite a margin.
Another 5 minutes. Yeah. So osteonecrotic hip, probably it is better to take a specific group that is called as atraumatic osteonecrotic hip in pre-collapse stage. Then if you take the intervention, probably the cause, the risk factor, prognostic factor, treatment of interventions, and you have to be precise and brief. So sample, just see, we have taken 3 categories like bone marrow aspirate, bone marrow mesenchymal stem installation, and PRP installation. But if you want to be very selective, probably we will take only one category that is called as bone marrow mesenchymal stem installation. Then the comparator group, it should be also very specific, clearly define what is there. So either I can take a code decompression with 8mm drip or 3mm multiple drill holes, and outcome probably selectively you should see what you wanted to see. Either it is a secondary surgery you will see in these patients, you will look for the total hip replacement or radiological progression and functional outcome. So probably the better question will be in this topic is the outcome of bone marrow mesenchymal stem cell installation better than standard core decompression in atraumatic osteonecrosis hip at pre-collapse stage? So this is more specific. So qualities of good research questions are clear. It should be target of population should be very clearly defined. It should clearly locate the time and location, and the point of view or the point of research should be clearly focused in that. So this is what many of the journals are also now asking, to have a specified questions in their article. This is what we propose: whether elevated serum interleukin 6 level at 6, 12, and 24 hours of in patients with skeletal trauma were associated with development of fat embolism syndrome. So we are very specified about the time, about the marker, and about the outcome, that is the fat embolism syndrome. So this is called as Goldilocks test, when you will say that one research question is perfect. It should not be too big, it should not be too small, it should not be too hot. That means it should not be sensitive enough where the patients or the researchers are feeling bored because of the long-term follow-up, or it is a frequent visit because of that. So it should be just right. So it should accommodate it properly. So turning research idea into research question, you have to be smart, you have to be specific, you have to evaluate those parameters which are measurable. It should be achievable, you should be realistic, and it should be timely. So to conclude, how to make a good, how you can make a good research question. Your research question should be relevant, it should be interesting, it should be within the scope of your facility. You should be informed, well informed about the recent literature. There should be originality or novelty should be there. You should be clear, and the last one is it is practical. Thank you.
Thank you very much, Sujit. Those were, extensive overview of very important topic. I would like to bring both, Dr. Goel and Sujit into a discussion. There was a, how to select a topic and which type of research to conduct should not be a different opinion. It has to be, first you identify your research question, what you want to do, and then on that research question you try to find out what best method will be to conduct it, which research method is best for that. Tarun, you will agree? Tarun and Sujit will agree to that point?
Yeah, sure.
Absolutely. Okay. Every type of a research question can be answered specifically by a different type of a research study. So the research should be tailored to the type of research question. So framing a research question should be the first step of starting your research.
Absolutely. And there was one question on chat box. A lot of chat box question has been answered by Tarun, and then I will request Sujit also to answer those questions. Most of the question, we'll take that question in our discussion part as well. One question was interventional. What are the type of study you conduct for an interventional study? I would just like to add to what Tarun has already answered, is that if it is one intervention, then it is going to be a case series, I guess.
Yeah, true. Absolutely.
If there are two interventions, then it has to be a controlled trials.
Yeah, if it is not comparative, then yes, it's a case series.
So exactly, that is why again, to emphasize that we must understand what is our research question, and then based upon research question, you decide what type of study we are going to do. Yeah. There are lots of discussion going on regarding the randomized controlled trial and all, from a apex medical college of our country. We'll discuss in our discussion part. So with this, I'd like to request, thank you, Sujit, for an extensive talk, and Dr. Goel for that. I would like to request Nagmani Singh, just quickly share his screen and show us technically how to do a literature search. Nagmani, all yours. Before Nagmani starts, in the meantime, just give me a sec, Nagmani. So next subsequent lecture will be on methods, the techniques. We just wanted to share our experiences. I personally believe that we are underutilizing various softwares in our research, and that is pushing us or putting more pressure on our research methodology. So how to effectively search a literature? Nagmani will start sharing his screen and show us how he very quickly does a research.
Good evening, everyone. Sir, is my screen visible already? Amit sir, is my screen visible?
Yeah, it's visible.
Okay, okay. So my topic today is going to be how to do a literature search in PubMed, and you see, this is a very exhaustive topic, and I would try my level best to bring it down in just 20 or 25 minutes. And I'll just be touching on the basics of the literature review in PubMed. So as discussed already by my seniors, so you've chosen the research and then you formulated the research question. As Sujit sir mentioned, you're supposed to conduct a literature research, because that will give you an idea about the whole or whether your study is going to be appropriate or not. So it's a very exhaustive procedure, and if you don't know how to systematically conduct it, you are going to lose your interest in research as well. So a proper way of performing a literature review is a must in any research which you are going to conduct. To begin with, there are multiple databases, and you can see N number like PubMed, CINHAL, Embase, SciInfo, Web of Science, Google Scholar, and Scopus, multiple of them. But all of these, or at least two or three of them, you only require when you're doing a systematic review or reviews of reviews, where you need to find a lot of things. But for most of our researches in modern day, as a busy clinician, PubMed is the database which offers almost everything which you need, and it's one of the easiest ones and freely accessible to all of us. So I would just be discussing about the PubMed today. So to begin with, PubMed functions in a different way. It functions with multiple operators. Like I'll talk about it when I start demonstrating practically. So there are certain terms called Boolean operators, truncations, and field tags, which I'll be elaborating. And there is a MES system, which is called medical specialized headings, and you need to form a keyword. So when you're doing a search strategy, it's not just that you search, but you should know how to conduct a systematic search. In that, for all my searches, what I do is I perform my strategy, using a Word document too. So let's take an example. So we'll start with a simple topic, and that's going to be meniscal tear in anterior cruciate ligament tear patients. So how do you find this in PubMed? That's something you want to find literatures on. So what I'll do is I'll put this question on my search performer. So you can see the broader aspect, and you can see that there are three concepts attached to this single question. So what are the terms which I need to actually look at? One of them would be meniscal tear. The other would be anterior cruciate ligament, or I can say tear. So these are three elaborate terms which I would like to see. So what I'll do is I'll divide them into three groups, which I'm going to conduct my search on. So this will consist of keywords and MES. I'll begin with searching the MES terms in PubMed. So what do you mean by MES? MES is basically a medical subject heading, and to put it in a crude word, it provides a uniformity and consistency to the indexing and cataloging of medical literature. So let's say a single meniscus, some of us might write a paper or form a question with meniscus as the heading, but it might be used by certain people as meniscal tears or menisci or multiple other or tibial meniscal injuries. So there are various words which describe the single thing which we are searching for. And PubMed would only talk about meniscal tear, like I've said, if I do not search with a MES term. So MES term, what it does is any literature covering it would actually be found out, and you are not going to miss any article which is of importance to you, and it helps you in doing a comprehensive research. So how do you use a mess? Just a sec, it's going to be loaded. Sorry, the internet is slow. Yep. So mess, suppose I'm going to research on, this is the way actually when you're looking at it, the PubMed lately looks like this. So when I'm going down, you can either conduct your research from the mess database here, or you can simply type in, which is a simpler method for a busy clinician. So let's say I'm going to do a research on this. So what's going to happen? I'm going to take, copy, and I'm going to paste it. Now let's say this is my whole topic, but I'll start with my first concept, and that's going to be meniscal tears. So I'll just stay crude, and I would like to find my mesh terms. So I'll type meniscal tears, and I'll see any Medline index paper. I'll click on it, which mentions meniscal tear. So if it mentions meniscal tear in the title and abstract, if you go down and scroll below on the right side, you will find certain terms called mesh terms. So what I'm going to do is, these are your mesh terms. So you can choose certain out of this. So in my case here, I just want to stick to meniscal tears. So ACL injuries is not my mesh term. Scrolling down, what I see is menisci, tibial surgery, meniscectomy, and others. So for my study, I would rather say that meniscal tibial surgery is the mesh term. So if I click on that, I can, the action link will show three steps, that is search in PubMed, search in mesh, and add to search. What I'm going to do is I'm going to search it in mesh. So when you look at it, this looks completely like PubMed, but if you look to the top, there is a title called mesh, and what you are seeing is meniscal tibial. So any article, if you go below and if you see the description, so any article which mentions tibial meniscus, semilunar cartilage, menisci, lateral menisci, or meniscus, these are various terms used to define a single lesion by multiple authors in multiple papers. So if I would have just written meniscal tear, I would be missing a large chunk of articles which are using different names. And that's what mesh does. So mesh will actually give you a comprehensive idea about what terms you're going to search with. So once I've seen this, what I'll do is I'll go to the right and I'll add this to add to search builder. Okay. So what I'm seeing is mesh, which is found in tibial fractures mesh and menisci tibial mesh. So what I'm going to do, I'm going to copy this and I'm going to paste it, and that's going to be by meniscal tear. So just like this, you can actually find multiple meshes which were mentioned in the heading. So I'm not going to explore on all of those. Similarly, what I'm going to do is I'm going to find the mesh term for ACL, and that's anterior cruciate ligament. Okay. So what I'll do is I'll just type it in and I'll get one article which is PubMed relevant to the anterior cruciate ligament. In the same way, what I'm going to do is I'm going to find my mesh terms. Here also, if you look at it, I just want to see anterior cruciate ligament injuries, which is pertinent to me. So what I'm going to do, I'm going to click on this. and I'm going to search it in MES. So if I search it in MES, now what I'm going to do, I'm going to find multiple terms. So these are all three MES terms which has been used frequently. If I want to use all three, I can select them and add to my search builders. For my purpose, what I'm going to do is I'm just going to go ahead with anterior cruciate ligament. I'm going to click on it. And these are the broader topics which it has been covering. So anyone who is using anterior cruciate, cruciate ligaments anterior, and other terms are going to be considered at this point. So what I'm going to do, I'm going to add this to a search builder. Fair enough. And this comes with a field tag called MES. So I'm going to copy this and I'm going to put it in my anterior cruciate ligament. So these are just one term which I'm going to put it out here. Okay. Now for tears, there can be rupture, deficiency, or this. So what I'll do is, and I'll go back again. And I'll search tears. When you look at it, they mention tears, but I want something which is relevant to meniscal tear. So what I'm going to do, I'm going to broaden the aspect and I'm going to take meniscal tear. So like I said, the previous search also, we've seen the MES terms. And if you're using it, it's going to come back to the same. So here also, if you look at it, it's tibial meniscal injuries, meniscectomy, meniscal tibial surgery, which I have already quoted out there. So looking at the literature, what I'm seeing is there is no MES term for tears. So once we have done that and we have, excuse me. If you look at the entire thing, I didn't have a MES term for tear. So what I'm going to do, I'm going to leave it empty. And then I'm going to, so this was one of the drawbacks of having MES because it will not identify all your things. So MES alone is not going to help you find all the article, but it actually provides you a comprehensive detail of a lot of it. So major drawback is newer articles which has not been in the, has a newer MES terms which has not been updated yet. You will be missing those if you're just searching the PubMed with just MES terms. Okay, so MES terms covers most of them, but it will not cover all the newer articles. Apart from that, articles sometimes are difficult to find. Like the way I showed right now, if I just put in tear, I'll find very vague random samples of articles which will not be elaborated by MES. So it becomes difficult at times. And then certain articles or previously published older articles with lower incidences might not have a MES term because it has not been published multiple times. The topic has not been elaborated a lot, and that might not have MES. And that's the place where the keywords come. So what are keywords? Keywords are certain things which you think about. Like, okay, what are the probabilities which I can use? What are the different ways in which I can say meniscal tear or meniscus? I can say meniscal, meniscus, or menisci. Those are my keywords. Anterior cruciate ligament. So MES has already given you a certain topic, but you feel that certain people might have just mentioned ACL in their surgery or ACL R or ACL reconstruction in their work. So you can use that keywords also. So it doesn't harm you by having additional keywords for anything. Just like that, when you look at it, I didn't have a MES term for tear, but several authors or several surgeons tend to describe ACL deficiency as ACL ruptures or ACL injury or ACL lesions. So what I did was I typed in tear as deficiency, rupture, lesion, or injury. So once I've prepared all this, what are the keywords and mesh terms which I'm going to do? Now what I'm going to do is I'm going to put all this and search. So search in PubMed, once you prepare your tags, is conducted by multiple things which we are going to use. There is certain things called Boolean operators. These basically enhance your search, which I'll be describing. And we basically use a building block approach. We search from larger single term by term, and then we narrow it down with these Boolean operators, truncations, and field tags and quotes. So Boolean operators are something which enhance your research. If you combine two words with an and, you're just going to find the articles with mentioning both of them. Or if you use or between two terms, it's going to find either the articles with ACL or either with meniscal tears. And suppose if you just want articles with ACL and not with meniscus tears, not is a Boolean operator which you are going to use. Truncation is something which you use with an asterisk. I'll be showing it now in a while. And field tags are certain things which describe. Just like mesh, if you type TIAB, that finds the words which you are going to use in search in title and abstract. If you are using TW, it's going to search in title, abstract, and metadata. If you're just using TI as field tags, it's not going to, it's just going to search those words in title of the article. AU stands for author, TA stands for affiliation, and AD is for the things. But the most common ones which a busy clinician should know how to use is TIAB, TW are the two things which they should know. And quotes are something which you put it inside the column. So we start with our basic paper using these Boolean operators and other stuffs. Sorry. Okay. So what you're seeing here in PubMed is I have already made an account. This is something I'll not be elaborating on, and this is something which Amit sir is going to talk about. I'm just going to talk about the literature search. So once I have made this, what I'm going to do is I'm going to type this entire thing just to do a quick review. So I'm going to use meniscal tear in anterior cruciate ligament patients. That's what I want to see, and I want to see how many articles are published out of it. So when you look at this, if you look quickly at this, you'll find that there are 984 results coming out with the topic meniscal tear in anterior cruciate ligament tear patients. But this research or this literature search is not going to mention both of them, or it includes all the articles which either mention anterior cruciate ligament or it mentions tears like you can see here, or whether it only mentions meniscus. So it's a vague kind of search and it's not goal directed. So you will land up with reading 984 articles. Out of them, 500 might be useful to you and 500 might not be. So what I'm going to do is I'm just going to show a quick way of using Boolean operators, and then I'll go specifically to this. So one quick way is I have three terms. So if I look at it, what I'm going to do is I'm going to put it between colons. So suppose if I don't put it between colons, my three keywords, if I don't put it between colons, it will search articles just with meniscus or just with tear. But if I put it along together, it's going to be meniscal tear and it has to be there in the article. Now what I'm going to do, my second key word is going to be anterior cruciate ligaments. Okay, so what I'm going to do, I'm going to put it there. Okay, and this is going to read as a single word. Now I'm going to use Boolean operators, that is and, or not. So suppose I want to find articles which has both an meniscal tear and anterior cruciate ligament. So what I'll do is I'll combine it with a capital and. And then I want to mention this in my words in title as well as abstract, rather than just finding it in title. So anywhere it is mentioned in title and abstract, I want this to be found. So what I'm going to do is I'm going to use field tags. So field tags, like I said, was TI is title and AB is abstract. So I'm going to put that here and I'm going to put that here because I want to find both the terms in title as well as abstract. So now what it is going to do is I'm going to search again. So now when you look at it, my result has narrowed down to 318 results. So this is something out of 784, 500 articles, or let's say 400 articles were something which I didn't need and I had to actually read it if I didn't use these Boolean operators. So Boolean operators are the operators which are used to enhance your research, like and, or not. These are field tags. If I just want to, let's say, now I just want to find it in titles. So let's see this. I'll just use TI. Fair enough. If I just use it in title and I conduct a search, what I'm going to find is just 19 results. So what you're finding here is meniscal tear and anterior cruciate ligament in all these articles are basically just mentioned in your title. So it's not screening abstracts for your article. Okay, so I just don't want. So what it is doing is my 384 papers were relevant if I also screened the abstract for the terms. But if I just use title, I have missed almost around 90% of the studies which might have been relevant to me. So what these field tags do is you have to be very cautious when you're using this. If you use it just for title, it's going to narrow down. If you want it in both abstract and all, make sure, that's why you're told that you start from a broader base and then you narrow down your searches. Now, just like that, if I just want to save this searches, I'll go and save it. Okay, or I can email it or send to, but for that I would need an account which I have created. Now there are another interesting facts about this PubMed page. If you go to the left side, I just want the studies which are recent from, let's say 2010 to 13 to 21. I just need to move it, and there have only been 12 studies which has been published in last 8 years. So if I just want to include studies of last 8 or 10 years, all I need to do is scroll over this button and I'm going to find. So PubMed does this for you, and these are some handy filters which you're going to use. Now let's say if I want free full text, so I just need to keep it here. And there are only 4 articles where free texts are available. So these are certain left-hand scrolls or filters which you can use in order to find your searches. Okay, so this is something I did. Now, what I'm going to do is I'm going to use these keywords to do a search on this topic, and that's going to be an example for this literature search. So what I'm going to do is I've already found meniscal tear and I found the keywords and then MES for all these 3 terms. So what I'm going to do is when you look at my keywords, meniscal, meniscus, and menisci are almost same. So what I'll do is I'm going to truncate it. Truncate is something, suppose, let's say the spelling of meniscus until menis, this C is almost same. So what I'll do is I'll just take this off and I'm going to put an asterisk over it. This is called truncation. So what it will do is the PubMed does is any word which is mentioned after this, like AL or US or CI, it will include it. But the beginning has to be minimum of 4 letters. Any word lesser than that, it is not going to truncate. So it has to be a minimum of 4 words. So what I've done is I've removed these terms and I've just truncated it. Okay, so I have mesh term and this and meniscal tear. So what I'm going to do is I'm going to form my final researches here. So I'm going to take this out. I'm going to put an OR. That's my Boolean operator. Now I'm going to put a apostrophe or a colon around this word. So this makes it simple. Other word which I'm going to do is I'm going to take meniscal tear, copy, and I'm going to paste it right in front of it. So I'm just putting merge formatting. Okay. So I'm going to unbold this, bold and unbold, and italicize, and then that's it. And what I'm going to do is I'm going to catch hold of this and I'll copy this. I'll put another OR here. And then what I'm going to do is I'm going to put this term here. Okay. So these are ORs. So any RTR. So first I'm going to do is I'll conduct a search with all these terms. So it will search all the articles which either mention meniscal tear or menisc or tibial fractures or mesh terms which was included for it. Similarly, what I'm going to do is I'm going to remove this. I'm going to put this under apostrophe, colon, sorry. And then I'm going to put ACL also in the colon. And I'm going to use Boolean operator OR for this. And I'll also use OR for this. Make sure your or and or not are not in small letters. It has to be capital in order to be read properly by PubMed. So I'll put again, okay, and I'll copy this mess and I'm going to put it there. Copy and then yes. So this is my second term which I'm going to search. Okay. Similarly for tear, it's going to be, I've already talked about meniscal tears with that. So tear is going to be or and I'm going to remove this and I'm going to put colon just like I put it in the first one. Okay, so these are my 3 search terms which I have made out of the entire keywords and mesh terms. So what I'm going to do is I'm going to make all the searches with these 3 terms. So rest, this gives me a brief idea. So first thing what I'm going to do is I'm going to use this whole thing So it will, and I'll copy it and paste it in my PubMed. Okay. Okay, here. So what's going to happen? I'm going to put it. So what this does is Word actually gives you keywords and mess, and it makes your search very strategic and systematic. So what this is now, after pasting it, what you'll find is this mentions 7,254 articles which mention either meniscal tear, meniscus, or tibial fracture using the mesh terms. If you look at it, truncation, when I used menisc, you can see it mentions meniscal, meniscus, anything which will be mentioned after SC, it elaborates on it on its own. So PubMed tends to elaborate everything on its own if you use an asterisk over it. So that's called truncation. So what I've done is truncation, Boolean operator, and mesh terms. Now, I can either save it or I can leave it. So what I'll do is, I'll go back again. I'll go back to my Word document, and once I've combined this, I'll find these articles. I'll copy it and I'll again post it in my this. So this is going to be my second search. So articles mentioning anterior cruciate ligament or relevance, there are 29,292 results. Now, once I've done this, what I'll do is I'll go to the advanced setting. If you look at the top, it finds it there. So what it will do is it will bring back to my history search. So the simple way of using Boolean operators, I've already elaborated before, and this is more systematic way of doing it. So if you look at it in history and search details, you can find whatever I have searched. So terms using an ACL, anterior cruciate ligament, and meniscal tear or meniscal or tibial fractures, you can find 29,292, 7,254 articles. Now I want to elaborate only on the articles which mention both of them. What I'll do is I can actually go to the action link, or I can directly go to this query box and I'll press *12 and I'll use a Boolean operator and *11 because *11. So the search number 11 and 12 I can combine in order to retrieve all my articles. So what I'll do is I'll search it again. Okay. So altogether what I have is 1,453 results. So these are just by combining my two. If I combine the tears also, let's say my search is going to be narrowed down to even lesser.
Dr. Nagmani?
Yes, sir. This is how you conduct the research. So I think I'm running short of time. So I've talked about Boolean operators, truncations, field tags, and mesh headings. I could have provided another example if the time permits, but that's something I would want Amit sir to tell me because
Dr. Nagmani, we have overshooted by 45 minutes.
Okay, sir. So we'll end it here, sir.
Thank you very much, Dr. Nagmani. Unfortunately, this was going really interesting. If you can stop sharing your screen, we can see everyone, and then
yes,
it was going really interesting. And there was my favorite, talk on how I use Mendeley for keeping my record, for keeping everything. Unfortunately, we are overshooted by 45 minutes, and then we have a lot of interesting discussion to go. So I want to skip my that practical session of Mendeley, and I'll make a video of that one and definitely submit to you in Nepali language. I'll submit into the group so that we all can watch that video and discuss as well. So without any further delay, since we are already very late, I'll go to the discussion part, and would like to thank Sujit, Tarun, Ravindra sir, and Lakshman Rizal, if all are here. Thank you very much for accepting my invitation to just have a discussion. So before we go for discussion, let me put out certain facts, of orthopedic research in Nepal. So this was a research, this was actually a survey which we did about a year ago among the orthopedic surgeons, and there were about 230 participants on that survey. And interestingly, everybody wanted to conduct a research, everybody, 230 participants of that survey wanted to conduct a research. So when we asked, have you published a research paper in last 1 year? You'll be surprised that 70% have not published a paper in last 1 year. So this was a 1 year ago. This was a scenario 1 year ago. Then we asked, is it difficult to conduct a research and write a paper? So you see, again, 70% said that this is difficult to do a literature and write a paper. This was a recent one, I analyzed, I have put in our group, there were about 230. Unfortunately, all are busy. 140 only answered to this anonymous poll. And if you see the people where they are working, you'll find out that only about 30-40% they are working in, teaching institutions, and majority are working in government or in the private hospitals. So this is the scenario of doctors of our country. So since the sample size out of 411, only 131 was there, I decided to go to the, the database of Nepal Orthopedic Association, where I removed about 100 people, the older generation. And then I included only 382 orthopedists who were registered in Nepal Orthopedic Association. And what I found was 61% of them were working in non-teaching hospital, and 149 were working in teaching hospitals. So about 60-40 ratio, to mention you, we have about 18-19 medical colleges. Exact number I don't know, but it was about 18-19 medical colleges. Another very important fact which will be used for discussion, I just want to bring to your notice and request all my panelists to pay some attention to it. So this was our recent Nepal Orthopedic Association journal. And then when I went through the authors from where they are, you will be shocked that 100% of NOAJ paper last time was from the medical colleges. So those from the teaching institution, not from the private, not from the government. Non-government institution, they have not produced any paper. And this doesn't stop here. The National Journal of our Nepal Medical Association has about 21 original paper, and out of these, only 2 papers are from the private colleges. Rest of all from the medical colleges. This is another PubMed index, our Journal of Nepal Health Research Council. If you can go to it, you will find out again the same thing. All the papers in the recent last issue were from the medical colleges, except one that come from Dr. Rajesh Chaudhary, who was here. So he's not from the medical college at this moment. So this is the scenario. This is the scenario at this moment. Everybody is interested, but the paper are coming from medical colleges. So my question is to, let me start with Tarun. So do we need to be an academician or work in an academic institute to produce a research, or it can be done in private small scale institute as well?
Yeah, I think this is considered to be one of the major hurdles or major mental block. I would say that the research should come from only the elite institutes or big institutes, but that is not right. I think for research, one need a research aptitude, and it is not limited by the institute or the place where you're working. Even in private institutes, you have a lot of material which is appropriate for teaching and research. A lot of your work that you are doing can be a material for your research. So the place we are working is not a limitation for research.
Okay, let me ask to my friend Lakshman Rizal, from he's working in private hospital. He has experience of working in medical colleges as well. So I have gone through his paper, and many of these papers were published from non-medical education or non-medical colleges. Lakshman, can you come in and share your opinion on what are the types of research actually that can be done in private institutes?
The papers that we published from the last 10-12 years, what I find is definitely we have not done the RCTs so far because of some limitations, because we have less number of patients and we have less time to gather data and analyze it. That is the only concern we are facing. That apart from that, we have published number of case studies, case reports, and some other comparative studies. So it's not the institute that matters for the research, but yes, definitely for some institute like medical colleges, they have some obligations for the promotions. So they do have to write paper. Otherwise, for the people who are interested in research, they can write wherever they are.
Thank you, Lakshman. I think that was very interesting. Probably the type of research differs between the paper coming from a private hospital and the paper coming from medical colleges. I was just going through some of the paper. I would like to commend that from BPKIHS there were lots of RCTs coming up. I'll not go into nitty-gritty of those RCTs where they true RCTs or it's not true, but RCTs were published from medical colleges, whereas case series are coming from private hospital. So Sujit, what is your take on that? So type of research differs that comes from medical college and private college based on the facilities we have?
Exactly, Dr. Joshi. I have seen that many of the cases, it is easy to publish case report, case series from the private institute. But when you need a randomized control trial where you need more frequent visits, the patient should not be aware of the treatment. Probably that is not possible in the private hospital because of certain limitations. Second thing is that you need certain funding for advanced things, like suppose, which are not necessary for the treatments. As I had mentioned, suppose you are evaluating the cytokines, suppose you are evaluating the biological markers. Probably in private institute, no one will give the money for that. But in academic institute, probably you can do in that for the academic purpose, or you can get a grant. So I think randomized control trial or better designed trials are possible in academic institute. But private institute, they need funding, but case series and case reports, those are things which is quite often that you can publish from the private hospital.
Or yes, Lakshman, I'll come to that. Or if I can put it a little differently, the kind of exposure of problems that a private institution has is different than a medical colleges. Medical colleges have a problem of residents, don't take it otherwise, but they have residents with whom you have to conduct a research. It's a mandatory. But in the private centers, this is not a compulsory. So you try to sort out your problems. And most of the problem is rather than a randomization, it's evaluating the practice, what you're doing. So could that be the difference in private and government? Yes, Lakshman, what you wanted to say?
The number of randomized control trials from the academic institution is just because they have to give thesis for the residents, and residents have to learn and they have to complete their thesis. That's how the RCTs are coming up from the academic institution, and they are getting published because residents, they are free and they have their allotted topics. So they are more into the research during that time. For a busy clinical practitioner or the private practitioner, this advantage is not there. He has to either enroll somebody for the research, or he has to devote his time that he can earn to the research. So that he doesn't want to compromise with that earning time. So that's the difference.
I absolutely agree, but a little bit of disagreement, Lakshman. It is, what is the problem you are having? Like 4 years back, we had a RCT coming from a private institution of my private practice, is that we just compared between a vertical incision versus an oblique incision and a horizontal incision for the harvest of the graft. So if your practice allows you to do a randomized control trial, probably you can do randomized control trial anywhere. So absolutely, that I agree. We'll go to our next question. I think Dr. Goyal very nicely elaborated all these, hierarchy of the research. And there was a question asked by one of our, participant, that where the systematic review of all the meta-analysis stands in the hierarchy. So its hierarchy is right there, so you cannot have a hierarchy above that. So whatever type of analysis you do, it will be the highest of the hierarchy if it includes those things. I'll not come to that. My question, this was the question asked in last meeting, we had about a month ago. We all know that having a patient, having a follow-up of that patient is really troublesome in many parts of our Nepal and India. So one of the participants asked, if we don't need any follow-up, we don't need any patient, why not to do a review, systematic or meta-analysis, or even a review paper, just sit in the table, look into the internet and write some review article. Why this cannot be done? I'll start with Tarun.
Well, it can definitely be done, but as also mentioned by Dr. Sujit before, whatever research we are planning or doing should have some relevance. So that is the most important point. Sometimes good narrative reviews are also one of the most read papers. Like you would see that they are one of the most cited or most read papers on social platform. So it's not that the review articles are not worth doing. They're definitely worth doing, but the content should be applicable and relevant to the readers. And similarly, meta-analysis and systematic reviews are very good studies to do. But again, they should be relevant in the sense that they are made upon a good research question and conducted well. And again, in systematic reviews, even relevant to the previous question that was discussed, in systematic review and meta-analysis, we get what we pour in. So like it's the quality of evidence. If you do a systematic review of case series or cohort studies or observational studies, it is as good as a level 3 evidence, nothing more than that. So we get what we put in systematic review. So we have to be careful about what we are doing in terms of the topic and the relevance.
Absolutely, Tarun. And then there is a classic term for all the review article: garbage in and garbage out. So what are the types of article you select for analysis? Your analysis result will be that. So it has to be. That is the reason why systematic review. So you do not in the garbages, you eliminate the garbages. That is why the systematic review have come. And the narrative review is a little different. I'll come to that. I'll come to Lakshman, who will give us a little bit of Nepali scope. Has he written any review article till date? I have not. Lakshman.
Yes, to start with, I was in my residency, and all of a sudden my professor said, I was doing a thesis on knee replacement surgery. So one fine day he came and he said, I need to give a talk in Hyderabad, and you find some papers for it. The subject is, we are revising the femoral stems with hydroxyapatite coated stems. So you try to find the papers, he asked me. Next day I searched some paper, I gave it to him, and I made a talk for him. I really gave some 3 or 4 days time for that, and I made a talk for him. And once he came from the talk, he said, you have collected so much of papers, and why don't you try to write a review articles on it? And that was on my second year of residency. I did a lot of work on it. And when I was in third year, it got published. My professor put so much of effort on that paper that it got published. So the first paper in my life, it was not a case report, it was a review article.
Thank you, Lakshman. I'll just go to the next slide. What is the difference between narrative review and the systematic review and the meta-analysis? Many people, they do not understand what is that. Just to, this is a diagrammatic representation. So narrative review is one of the simplest to do. So you summarize, you read a lot of paper, synthesize the information and come up with the narrative review. And there was Rajiv was asking what is the scoping review. Scoping review is a more wider type of systematic review. A narrative review is something that is very easy to write, but unfortunately these narrative reviews are not taken as a publication. These are invited papers. So all of a sudden I just want to wake up today morning and then decide that I'm going to write a narrative review because I can today I learned how to search. Nagmani showed me how to search the literature, and based upon that I'm going to do a narrative review. It's not going to happen that. So usually narrative review are the invited paper by journals to the expert of that particular field. The systematic review is a true research, but it requires lots of system involvement. Nagmani showed one aspect of combination of search term. So in systematic review, what happens? You do not select the topics that you like. So let the system select the topic for your synthesis of the summary. So that is your synthetic review. And then another one is can you mute please? Okay. So the meta-analysis is something which is kind of systematic review, but more focused, and it utilizes data. So systematic review utilizes information, whereas it utilizes data. So meta-analysis, just to simply understand, there were under par papers. Someone has 40, 50, 70 sample sizes. So if you summarize all those sample size and do a re-analysis of the data and then produce a result, that is going to be a meta-analysis. That is what a very simple word to understand. And probably at this moment, many papers say that there is a tsunami of review articles. There will be one point of time when many journals will say that we will not accept a review article. That is what happening. And again, there are various combination. This is a systematic review or meta-analysis. So these kind of things are happening, which is more, higher in the reliability of various research. So with this, I'll come to randomized control trial. There was a lot of discussion. I'll just go to quick one. If you go to current literature, the question is to Dr. Tripathi, to you, that if you go to literature, there are lots of controversy coming up with the randomized control trial regarding more bias in the randomized control trial. So these are few papers I have put it here. But as you said, and the Dr. Goyal also said, that probably the highest level of interventional study is the randomized control trial. Can you just highlight us what are the barriers to do this randomized control trial? Not everybody can do this.
Yeah, there are several barriers in performing a randomized control trials. Obviously, we have certain guidelines how to do the randomized control trials. And if you follow that particular guideline, probably we can properly follow it. But the barriers in terms of, I am saying, is first of all, the patient, or getting the patient properly. You have to take consent of the patient properly so that they will be randomized to one group and the control group should receive the other treatment. That is one of the problem. Second is the funding issues. Third is it needs a frequent follow-up, which is not possible in many aspects for many of the researchers. So in busy clinical practice, probably it is not possible to get all the patient in time. And the fourth thing that I believe is that the major barrier is that for these randomized control trials, the patient, the funding, I have already mentioned one of the major issue of this problem is the funding, which needs this one, frequent follow-up. And if there is any complication, probably you need to insure their patients for all randomized control. These are the major barriers. And definitely in patient recruitment, I still believe that the biases are there because many times it is not easy to perform a randomized control trial in all studies. These are not justifiable, but even then, because of the better quality or better evidence, probably we do that.
Thank you, Sujit. You would like to add something, Dr. Goyal?
I think these are the points that would be difficult for a person to just for a randomized control trial. Yes, these are related to the funding issues, and these are also sometimes related to the difficulty in doing randomization. I think Dr. Sujit has covered this point, sir.
Okay, Lakshman, you want to add something?
Dr. Sujit and Tarun, they have covered all the things. This is not very impossible, but possible. There are some limitations. If we can stick with that limitation, we can start that randomized control trial also.
There was a lot of discussion on sample size calculation in randomized control
Yes.
trial. I would like to highlight that sample size calculation is one of the backbones of randomized control trial. Doing an undersized randomized control trial would be of no good. So, and sample size calculation is not very difficult. It is there's a lot of hype about sample size calculation, but it is not at all difficult. What you need is some baseline data on the topic that you are planning for research, and using that baseline data, you will be able to calculate the baseline prevalence of that disorder or whatever incidence of your primary outcome. And that's all you would need for sample size calculation. It can easily be done online, and that should not be deferred.
Yeah, Tarun, I agree. That was my next question. But if you go to how the RCTs are done, RCT has to be registered first into the registry. RCT registry itself is a long process, and it requires so many requirements, And then once your RCT is approved, then you implement it. There are a lot of ethical issues and the ethical values involved into it. There are lots of biases also involved into it, and these biases are more compared to the other thing, because so many people will be involved into collecting your data, analyzing your data, all kind. And then finally, randomization properly done or not, and then sample size properly calculated or not, under, as Tarun was saying, undersized, undersampled randomized control trial is not going to do any good for any of the research. So maybe in our context, we can carry away with the randomized control trial in the title. But if you talk about a good, high, quality journals, they will look at if it is a randomized control trial, they'll look at the sample size calculation first. If it is convenient sampling, then it's directly not going for publication. So what I mean to say that randomized control trial, though it is the apex of interventional studies in its various combination and permutations, but conducting these trials are very difficult. So in conduct, if you compromise in conduct, then your outcome of the randomized control trial is going to be compromised. That is probably one of the reasons why not everybody can do a randomized control trial, especially when a surgeon is busy, they have to do meticulous follow-up in all the time. I think that is what Lakshman was also trying to say. Okay. So again, this was a question. I took it from the previous discussion. I wanted to take opinion of Tarun and Dr. Tripathi, that case reports. So what is your take on case reports? So what is its academic value and what is its scientific value? In Nepal, I don't know what in India. In Nepal, case reports are not considered as an academic publications. So I don't know what in India you can share, but I think what is your take on scientific value of case reports or learning experience for a busy clinicians or learning surgeons, the case reports, how you take it? You start from Tarun.
So they are not considered to be an academic publication in India as well. For example, if you take it for promotions for various other, your PPRs, then it is not considered to be credit. It's not considered to be of the same credit as a full-fledged publication, as a full-fledged article. So it's not considered as a full-fledged article. And but at the same time, we cannot just rubbish it saying that it has no academic contribution. Although we should also understand that most of the good journals have stopped taking any case reports. It's difficult to publish a case report in a good journal, and it's sometimes we do have some very rare scenarios which are worth reporting, which may be accepted in good journals as well. but those are exceptions. Those are very rare situations.
Okay, so can I start?
Yeah, Sujit, go ahead.
Yeah.
Let's make a quick fire, Sujit.
Yeah, that's fine. So what Tarun said is right. Actually, most of the journals, they are not accepting the case report, but I don't believe that these case report doesn't have any scientific value. That is wrong. I think it has a scientific value, but the problem with the journal is that they want a impact factor. And these are based on the rare disease, rare treatment, or rare clinical features. So if you publish a case report, it is unlikely that it will be cited within the next 2 years. So it indirectly impacts the impact factor of the journal, and probably that is main reason why most of the journals are not accepting the case report. But if you ask me, the scientific value, it is there because it is reporting a rare disease, rare treatment modalities, rare clinical features. And India is a huge population, almost 130 crores populations are there. And you will definitely get something miraculous things happening here. That is, the rare presentation will be there, or some people may be doing some rare type of treatment. So I think it has a value, and there are certain journals also available, Journal of Orthopedic Case Report, who are exclusively publishing the case report. I would like to give one or two examples that why it is important is that in Claude Bernard, who first did the heart transplant, if you see, he published initially one case report, which was a heart transplant. So subsequently, it became standard procedures. If you see that was written Australia. In Australia, obstetric and gynecology, the people, they published the first case of thalidomide fallacy. That means what happened to the children where the mother took the thalidomide, the focomalia and all these things. And it was initially published as case report, and subsequently the company has to stop or recommend that thalidomide should not be taken during the pregnancy. So that is the scientific value of the case report. We cannot deny that. But the problem has the journal has their own issues related to impact factor, and that's why they are not accepting. Yeah.
Thank you, Sujit. I would like to ask Lakshman, because he's master of publishing case reports. Give him anything, he'll publish it. It should not be, it may not be a rare case, but he'll publish. I know, I've read his a lot of papers. Lakshman, can you come in and give us some input on case reports publication?
Let me start with one case that we published. That was a case of hemophilic pseudotumor, and we did a radiation therapy because there were few cases published beforehand. So we compiled all the cases, and then what we did is we did a case review on the effect of radiotherapy on hemophilic pseudotumor. That made our case report more weighty to get published. So definitely it has got a scientific value because there are so many cases reported less than 5 or less than 10. And this gives you an idea to treat about that condition, as well as writing such cases will eventually form the basis of treatment in the long run. So that's how they help in the scientific aspects also.
Thank you, Lakshman. I think I absolutely agree. And then all the panelists, they have, voiced their word in saying that we should not discard case report. Although these are not, if you are looking for a promotion, probably case report is not the type of cases in which you should spend time. But the learning objective of case report is more focused. You learn about one disease, one condition, and one aspect of that thing. And it's a fantastic tool to learn. May not have an academic value, but I think it has a heck of a scientific value. And that is what all the faculty have said. So this is, again, coming to the Nepal Orthopedic Association journals, papers. This is original article published in our latest issue. And then if you go into that, so these all come from medical colleges, but none of these are randomized controlled trial, and all are case series. You see, these all are case series. And I'll show you another one. This was not, the scene is not gloomy in Nepal only, Go to Indian Journal of Orthopedics. It's the same. These are the case series. So if we talk about current trend, the trend is not of randomized controlled trial at this moment. Probably many people are going towards the review papers and the case series. So what is your take on case series? I'll start from Lakshman. Quickly.
I consider case series, I consider first of all the case report as the basis of scientific writing, the first stage, and the case series as when you grow mature, and that's the time when I consider the case series to be written. So it's a simple thing to be in the study and get it published, so people are more interested, I think, because how to design a good case series. I can see one author, Mohit Bhandari. He's a top notch in writing papers, but still he is writing on this simple topic, how to design a good case series. See, that's the difference of the good writer.
And I think if I have to give my input on what type of research we should do in a busy practice, is probably this is the type of study that you have to go ahead that suits more to your practice. You do that research which suits to your practice, you enjoy doing it, rather than burdening yourself and overburdening yourself. Dr. Tripathi, your views on case series?
Yeah. You're absolutely right. For a busy practitioner, suppose you are doing the surgery in the private setup, or you are a busy practitioner, probably it is good to do a case series, because we are operating on so many cases and we need some follow-up and we can easily publish this. So it is simple. Second thing is that here most of the cases are retrospective. That means you have done in good intention with proper selection of the cases at the initial time. So whenever you're doing a prospective study or randomization, there is problem that you have to categorize those patients to some unidentified treatment. So that is the risk, but here there is no risk. So probably it is good to start with case series, and that is quite feasible in private practice as well.
True. I'll just modify a little bit of question coming to Dr. Tarun, that case series is probably current trend everywhere. At least in Nepal and India, I could see that case series are current trend. So, what is your opinion on loss to follow up? In your practice, what problem does it create? Is it a problem, loss to follow up, in your personal practice?
Yes, it is. Loss to follow up is something reasonably common, and although it is not totally unavoidable, but generally we say that if it is more than about 10% of loss to follow up, then the study may be losing its relevance. So one of the methods, like with digital case records and with electronic systems available, I think we these days we try to keep all the possible electronic records of the patients, including their phone numbers, their email IDs, and the alternative phone numbers, the alternative email IDs, the addresses, the Aadhaar numbers. And by this, we are, trying to minimize. Plus, the hospital data is, with the HMIS hospital information softwares, it is electronic. So even after a certain period of time, it will be possible to again go back to the demographic details of the patients and get the addresses and phone numbers available. But even I agree that even in our part of the country, loss to follow-up is still very high, and it is a problem in any studies that we perform.
Lakshman, can you present us Nepal's perspective, loss to follow up?
The reason for loss to follow up is either the patient is normal, he doesn't need any more treatment from his part, not from my part, and either they are not normal, so they want to seek advice from somebody else, or they are no more. So I categorize it as 3N: normal, not normal, or no more. So that's how it really affects in our part also, because most of the time we get the patient from the periphery and they never come once you operate. And how do they differ? How do they differ in our study is, if it is less than 5%, that doesn't make a difference. If it is more than 10 or 20, that really damage our study, making it less liable or less viable, because it's the denominator in the RCT. It's one of the denominator that we consider, that number of patient randomized gives the denominator. So that helps if there is a loss in follow-up that really damages our study. And in case of retrospective study, it damages less, because we consider the total number of patient getting treatment as a denominator. So more damages it gets to the randomized control study whenever there is a loss in follow-up. So that's what we really hesitate to start the study on RCTs as well, because most of the time, if we consider operating the patient or treating the patient from more than 20 or 25, 30 kilometers far from our center, there is less chance that they will come for the follow-up.
Absolutely, Lakshman. Loss to a follow-up is major constraint, but in my practice, what I've seen, I've worked in medical college also. Now I'm working in a private setup. But in private setup, what I see is there is more person-to-person contact. There is a patient who will come searching for Lakshman Rizal. He will not come searching for one particular medical college. That is why probably in a private setup, it is more easier to follow them up by using various methods like Tarun was saying. And then in government hospital, maybe you are right that if someone is, I don't feel comfortable to go to that place, then they turn up to some other place, and loss of follow-up is a key issue. This was one of the paper, which we submitted to, this was our paper. I would just like to show you that this was just calculated. The dropout rate of a retrospective study was calculated to be 21%. So because of this reason, this our paper was rejected from a very reputed journal. But we are submitting it to the other one where it has been provisionally taken. But we wanted to publish this to a very reputed journal, and only on the basis of your data may be misleading. Your methodology is faulty, that you were not able to follow up all these patients. This paper was rejected. So another one, just an example. This is not only in a case series or retrospective studies. This applies to RCTs as well, and then calculation of dropout rate in RCTs are little different. You do not calculate from the whole total number of the patient. You rather calculate from the treatment instituted. So these are two calculations. I'll not go into detail of that, but 34% and 30% dropout rate is completely not acceptable in case of randomized controlled trial. So now if we identify this criteria and put this criteria of 20%, the highest order in randomized controlled trial of published paper of our country, then there is a lot of issue on our randomized controlled trial. Tarun, you turn your video on. You wanted to ask some question, or you wanted to comment? You are muted, Tarun. You are muted.
No.
Okay, so the final question is, how much is too much loss to follow up in your take, Dr. Tarun? Unmute, please. Yes.
Yeah, I would say that loss to follow up of 10% or more would be too much for follow up.
Absolutely. I tried to screen our papers, in which loss to follow up were mentioned in 90% of our papers coming from Nepal and India that I have screened. The follow-up rate was more than 10%. Dr. Tripathi, your take on this, how much is too much?
Yeah, actually, if you see the literature, it has been mentioned that 20% is the acceptable level, as you mentioned it. But if you ask me really, that it should be as low as possible, preferably 5 to 10%. That means I agree with Tarun that it should be within 10%.
Absolutely. That is what most of the journals say. If it is, and Lakshman was also saying that if it is up to 5%, it doesn't affect. And then as it goes further, it start affecting. And it also depends upon the sample size. If you are taking, 10,000 sample size and there is a loss to follow up of 20%, may not be, so much effect, important. But if you are taking 100 patient and there is a loss to follow up of 20%, then it's going to make a heck of a difference in your outcome.
And I completely agree with Dr. Lakshman. He was very right that patient will not come if either he has done extremely well or he will not come if it is totally bad for him. Actually, these are the two ideas that is behind the patient's denial to come to the hospital.
True, Sujit. And unfortunately, we don't know in which limb the patient is. Either he has done good or he has done really bad that he didn't come to us, So that is why the outcome will completely be different if your follow-up lost to follow-up. So if you look from this aspect to your research, when you read your paper, when you read others' paper, the loss to follow-up, and there was one paper, interesting paper I was reading, where it was not mentioned. So it was a retrospective study. They included only 30 patients, and they have not mentioned how many surgeries have been done of that particular method. And they have included only 30. There may be 100 surgeries have been done, but they have included only 30. It's outright, methodology is not correct. So probably follow-up is one of the issue, and we all have to identify a way by which we can, maintain our follow-up. So this was my actually last question. My paper was rejected because it was just above 20. So that is why it was rejected. They say that they will take up to 20% dropout rate. So it depends upon journal to journal also. We have to go to instruction to authors, and now they are emphasizing more on a dropout rate or a loss to follow-up rate. And that paper where we submit, they say that we accept only up to 20%. So unfortunately, and there are, I have, as Sujit and Lakshman, everybody was saying, there was some paper who said that more than 10% dropout rate will not be, forwarded for any further revision. So with this,
Dr. Amit,
yes. Who is this?
My take on this loss to follow-up is, Lakshman, my take on loss to follow-up is no news is good news.
No news.
Second thing, why I am not saying that it should be 20%, there is a reason behind that. Probably we know that suppose we have compared two groups and 10% of this group are not coming for follow-up, 10% of this group. And these 10% are doing extremely well, and these 10% are doing extremely bad. So if you combine that into your analysis, probably then it will be 20%. It will affect your final analysis. So that's why how does your loss to follow-up patients are behaving, that is important, whether they are doing well or they are doing bad. So that's why I mentioned 10%, because if this 10% of this particular group is doing well and that particular patient also doing bad, then probably it will become around 20%.
I absolutely agree, Sujit. The 20% I quoted was from a very reputed paper. It depends upon what, but I absolutely agree. If you can have a zero dropout rate, nothing better than that. No news is good news. Good news for whom? I don't know. Good news for the doctor or good news for the patient? So what I mean to say that whenever we start a research, these are the basic things we all should understand. So you conduct a research, spend your 1 year, spend your time, money, and everything on it. And at the end of the day, your research is not, very valid for a publication. Then it's going to be a little, trouble for everyone. So that is why it's important to know all these kind of small nuances of doing a research. That was the whole purpose of this discussion. We have overshooted by half an hour, but I can still see there are 136 people. I'll give you 1 minute to each of you, Sujit, Tarun, and Lakshman, if you want to say some final words.
Yeah, Dr. Joshi, this is my first interaction with Nepal Orthopedic Association. I have gone to Nepal many times, but probably in a research forum, virtual meeting, probably this is the first time. And I can see that means I have delivered almost 50 lectures in last 1.5 years during this COVID pandemic. And this number of this 145 participants participating in a research questions, then research PPT is extremely high. And that is really thankful to all these members who are watching this and who are interested really in research.
Tarun, final few words.
Yeah, thank you very much for inviting me to this event. This is again.
Tarun, we lost your voice. Okay, I think there is some problem with the voice of Tarun. Lakshman, your final few words.
I'm very, very happy to express that the fire for the research is on everywhere in Nepal, and we should maintain it.
Thank you, Lakshman. Tarun, you are back with your voice.
Yeah. Can you hear me now?
Yeah.
Okay. So I was saying that, yeah, I'm really grateful to Nepal Orthopedic Association for this, because this is again my first interaction with Nepal Orthopedic Association. And as Dr. Sujit said, I was surprised that there were quite a large number of people who were really interested in the research seminar, because generally in orthopedics, we find it difficult to encourage and motivate people to come and join for a seminar, that too on a Saturday evening. And I'm really impressed with the number of people who are actually dedicated to joining the seminar, plus a bombardment of questions on the text boxes for on various topics. Thank you for such an interested audience.
So thank you very much. Before I hand over mic to our secretary, Dr. Binod Sersan, Secretary of Nepal Orthopedic Association, for vote of thanks. I personally would like to thank Sujit, Tarun, and Lakshman, for accepting our invitation to discuss all these simple matter with us. And for Nepalese colleagues, I have a notice put onto the group that there is a link for CPD point claiming, which will be open for 1 hour. So you can go and claim CPD point, or Nepal Medical Council CPD point. Dr. Binod Sersan, Secretary of Nepal Orthopedic Association, if you are around, please unmute yourself and give us a vote of thanks.
Thank you so much, Day. Am I audible, Day?
Yes, Binod, audible.
Okay, thank you. Respected seniors and dear colleagues, very good evening. First of all, on behalf of Nepal Orthopedic Association and myself, I would like to express my sincere thanks to our invited faculty, Dr. Tarun Goyal and Dr. Sujit Tripathi, for giving their valuable time to us today and guiding us and our young colleague toward the path of research. I would also like to thank our own faculty, Dr. Nagmani Singh, for your elaborate explanation and practical demonstration regarding how to do literature search in PubMed effectively and efficiently, even though there were some time constraints. Thank you so much, Dr. Lakshman Rizal, for participating in panel discussion, which all of us enjoyed much. And we look forward more of your involvement in academic activities of NOA in days to come. Last but not the least, a very big thanks to our Vice President of Nepal Orthopedic Association, Professor Amit Joshi, who have taken all the pain in organizing this research workshop by collaborating with all the faculties and planning every minute details of this workshop. On behalf of NOA, I would like to thank you once again, sir. My sincere thanks to all the participants for taking interest in research workshop and joining us today at this odd hours, that too a Saturday holiday. We had a fruitful discussion because of your active participation, and we had almost 150 participants today. So this shows the interest of our colleagues for research. Thank you all. Lastly, on behalf of Nepal Orthopedic Association, President Professor Ravindra Pradhan, I request all the faculties, especially our friends from India, for more commitment for us in further workshop too. We look forward to see you in the next another series of research workshops. Thank you so much. Stay safe and goodbye.
Thank you very much, Binod. Again, not to forget Dr. Nagmani Singh, who was available to demonstrate his skills on internet and PubMed. Hopefully, I'm sorry that I have to skip one another 30 minutes practical session of how I use Mendeley, Zotero, all this kind of stuff, softwares to organize my research and organize all the thought process in one place. I think that is what we all are lacking. Most of the clinicians are lacking certain basic software skills of computer. That is making the research a little more difficult than others. So hopefully I'll make a video and put into the group so that you can watch that video of presentation in n number of time. With this, I'd like to thank everyone sparing your Saturday evening. Thank you very much. Sujit, Lakshman, Nagmani, and Dr. Goyal. Thank you very much.
Thank you. Thank you all.